Ghana spent 2 decades fighting one of the most successful public health campaigns in Africa, and won. In 2012, malaria killed 2,799 people in Ghana. By 2022, that number was 151. A 95% collapse in a single decade. International health agencies use Ghana as a case study in what works. But while everyone was celebrating that victory, something else was rising in the background, and it had already become the country's leading killer before most people noticed. Ghana. Roughly 35.7 million people, one of West Africa's most stable democracies, and an economy that's grown steadily enough to push GDP per capita past $3,300, meaningfully higher than several countries we've covered on this channel. Life expectancy sits at 65.7 years, still well below the global average of nearly 74, but climbing. Here's the number that matters most for this episode. 59% of Ghanaians live in a city. That's the opposite of what we found in Ethiopia, where only 23% were urban. In Ghana, the urban story isn't a small slice of the population. It's the majority. And in 2003, Ghana launched something that would later be called, by Bill Gates himself, the most successful healthcare system on the African continent, the National Health Insurance Scheme. It was built to make basic healthcare accessible to ordinary Ghanaians. It worked. And it was built almost entirely around a very specific kind of disease. Before we get into the catch, here's your true or false. Malaria is still Ghana's leading cause of death. The answer is false, and the data shows it's been false for years. According to a national study of Ghana's health facilities between 2014 and 2018, non-communicable diseases were already the leading cause of death. 25% of all recorded deaths in 2017, 20% in 2018. Infectious and parasitic diseases came second, at 15% both years. Respiratory infections came third. Within the non-communicable category, one condition stood out above all others: hypertension. High blood pressure was Ghana's single leading specific killer, followed by other heart conditions and diabetes. Nationally, looking at the country as a whole in 2023, the picture is even clearer. 126,000 deaths from non-communicable disease, compared to 89,700 from communicable disease. NCDs aren't just leading, they're leading by a wide and growing margin. And there's a geographic pattern here that should sound familiar if you watched our Ethiopia episode. Researchers found that non-communicable diseases show a clear urban bias, while infectious diseases remain more concentrated in rural regions. 4 regions, Greater Accra, Volta, Upper East, and Upper West, actually saw death rates rise during this period, even as the national average improved. Ghana's malaria war is essentially won. Its NCD war has already started, and in some regions, it's not going well. We've already covered the biology of hypertension in depth on this channel, the silent arterial damage, the heart attacks and strokes it causes without warning. Ghana's version of that story has the same biology. What makes Ghana's episode different is what happens after a Ghanaian is actually diagnosed. Because Ghana, unlike many countries we've covered, built something that should have solved this problem. The National Health Insurance Scheme. Launched in 2003, the NHIS was designed to give ordinary Ghanaians access to basic healthcare without crushing out-of-pocket costs. It covers 95% of disease conditions, including, on paper, treatment for diabetes and hypertension. By 2017, it covered 47% of the population. This is, by any African standard, a genuine achievement. So here's the catch. A 2025 study by Ghana's own National Health Insurance Authority, working with international researchers, found that affordability remains a major barrier to chronic disease treatment, even for people enrolled in the scheme. Out-of-pocket costs still determine whether patients stay on treatment or quietly stop. The numbers are stark. The mean annual cost of managing diabetes in Ghana is over 3,000 cedis. The lifetime cost of treating hypertension can exceed 869,000 cedis, depending on age and severity. For the NHIS itself, diabetes and hypertension already rank among its top 5 cost drivers, consuming over 10% of all claims. And here's the detail that should genuinely surprise you. The same study found that NHIS members were actually less likely to monitor their blood pressure or stick to their medication than people without insurance at all. Why? Because the benefit package, on paper, covers consultations, medicine, and lab tests. But in practice, the coverage routinely stops at the consultation fee. One woman in an urban ACRA study, managing both diabetes and hypertension, put it simply, she'd been told her medicine was free. Every clinic in her neighborhood charged her for it anyway. This isn't a story about a health system that failed. It's a story about a health system built brilliantly for one epidemic, discovering in real time that it wasn't built for the one that replaced it. Let's put the two timelines side by side, because the speed of one and the slowness of the other is the whole story. The malaria timeline: 2,799 deaths in 2012. By 2022, just 151. A nearly total collapse in exactly 10 years, driven by bed nets, better diagnostics, and a national strategic plan that's now explicitly aiming for elimination, not just control. This is one of the fastest single-disease mortality declines documented anywhere in this series so far. The NCD timeline moves in the opposite direction and on a longer arc. By 2017, years before Kenya's national crossover was confirmed by government data in 2024, non-communicable disease was already Ghana's leading cause of institutional death. The NHIS, meanwhile, was launched in 2003, explicitly built around the disease burden Ghana was about to spend the next 20 years successfully fighting. Nobody designed it with 2025 level diabetes and hypertension costs in mind, because in 2003, those weren't yet the dominant threat. The system was built for yesterday's epidemic and is now playing catch-up with today's, and Ghana's government has noticed. In June of 2025, the country uncapped its national health insurance levy, specifically to free up more funding for chronic disease care. In April of that same year, President John Mahama launched a new fund called Mahama Cares, specifically to finance NCD treatment that falls outside what the NHIS currently covers. This is a live correction happening in real time, not a hypothetical fix. Ghana is trying to retrofit a 20-year-old system for a disease burden it wasn't originally designed to carry. If this is starting to sound familiar, that's because it is. Kenya beat HIV and watched NCDs rise to take its place. Ethiopia's capital crossed the same threshold over a decade before Kenya's national data confirmed it. Now Ghana, having all but eliminated malaria as a mass killer, is finding that the system built to win that fight isn't automatically equipped to win the next one. 3 countries, 3 different specific diseases defeated, the exact same pattern emerging behind each victory. This isn't a coincidence, and it isn't really a story about any one country failing. It's the well-documented shape of what happens as nations develop. Infectious disease falls, chronic disease rises to fill the space, and health systems, built urgently, often brilliantly, around the crisis in front of them, need to be rebuilt again for the crisis that's already arrived. Ghana's specific contribution to this pattern is a warning worth remembering. Even an internationally celebrated health insurance system, the kind other countries study and try to copy, can be doing everything right for yesterday's disease while quietly falling behind on today's. The story this channel keeps finding, country after country, isn't really about death. It's about the gap between when a health system is built and when the disease it needs to fight actually arrives. Next, we're going to Cameroon, a country dealing with a health crisis layered directly on top of an ongoing conflict most of the world has stopped paying attention to.